and Assalamu alaikum. Good afternoon, faculty. I am thankful to faculty members. The topic of my presentation is posterior fixation, including the fracture vertebra for unstable thoraco lumbar fracture. Basically, it was prepared by Dr. Riazur Rahman and me. Dr. Riazur Rahman has got another presentation in Xavier Hall, so he could not present this topic. Advantage of this procedure or this presentation is to prevent neurological deterioration and give better chance of recovery. It gives good mechanical stability. It decreases pain, facilitate early aggressive patient, and arrest deformity progression in early post-op period. Bony grafting maintain the fusion of the fixed segment in long term. The target was to achieve therapeutic goals in short and long terms, preserve as many motion segments as possible. There are three options: long segment fixation, short segment fixation, including the fractured vertebra. The third one, which we are going to highlight, is this one. The study of our topic is mainly dependent on this topic. So first is long segment fixation. Actually, these are strong fixation with good biomechanical stability, but it creates long fusion segment. The main drawbacks of this is they take longer surgical time, which may increase the chances of increased blood loss and greater chances of the infection. Also, it creates long fusion segment. Traditional short segment fixation, they achieve therapeutic goals in short term, but there is more chance of implant failure and failure to stop kyphosis progression. Posterior fixation, including the fracture vertebra, a novel idea used to avoid the shortcomings of transpedicular screw fixation. It avoids the suspension effect, dispense the internal fixing load, reduce the correction degree losses, reduces the incidence of internal fixation fracture. Posterior fixation, including the fracture vertebra, it avoids the need for anterior reconstruction by increasing the height of compressed vertebra. Preserve normal motion segment and less bleeding and soft tissue damage. Our study objective was to determine the surgical outcome of pedicular screw fixation, including fracture vertebra for unstable fracture at dorsolumbar junction for unstable fractures. Study design was retrospective and descriptive study, which was carried out in Department of Neurosurgery, Lady Reading Hospital, Peshwar, and Hyderabad Medical Complex, Peshwar, from January 2017 to March 2018. Those patients with traumatic unstable fracture at dorsolumbar junction from D11 to L2 from all age groups and both genders were included in this study. Those patients who has got fracture with very retropulse segment requiring anterior removal, where pedicles were shattered and screwing was not technically possible, and those patients who were having stable fracture were excluded from this study. Assessment, initial resuscitation following the standard ATLS protocol, complete detailed history and clinical examination and essential investigations. In radiology, first of all, we go for the plain radiograph, which might be in different view, AP lateral, and CT scan to see the bony morphology, bony anatomy, and third is the MRI scan to see any ligamentous and soft tissue disruption. Positioning, here we can see the patient who has got thoraco lumbar junction vertebra fracture. They are placed on Wilson frame in prone position. And then we can see the pedicle screw has been inserted through the pedicle in one level above and one level below the fracture vertebra. And in this, we can see that short screw has been placed in the fracture vertebra also. We can measure the size of the rod and insert in the screw heads, and after that we can do decompression if there is any bony fragments compressing up on the spinal cord. Then distraction can be done and gently the screw heads are fixed with the fusion. Although fusion was routinely performed for all spinal fracture, Its indications are now being restricted to fractures that are highly unstable. Non-fusion fixation can be performed for A3, A4, and B1 type injuries. Fusion is routinely performed for A2, B2, B3, and all C injuries, as they are unstable injuries with extensive soft tissue and ligamentous disruption. In our result, there were total number of 43 patients. Males were 27 and female were 16. Mean age group was 30. Range was from 18 to 67 years. Etiology was 21 number of patients, they experienced fracture vertebra due to fall, and 16 patients due to motor vehicle accidents, and others were 6. Site in 21 patients there was first lumbar vertebra fracture. In 17 patients there was 12 dorsal thoracic spine fracture, and in 3 patients there were L2 fracture, and in 2 patients there was T11 fracture. Radiological measurement. After the procedure, we discharged the patient, and this measurement was followed after the in follow-up period. The mean Cobb angle was improved from preoperative 7.4 to 1.7 millimeter, 2.2 millimeter postoperatively. The preoperative mean anterior and posterior vertebral height were improved from 17 and 26 millimeter to 27 and 39 millimeter respectively. Complication in our study was there was dural tear while doing the posterior decompression in 3 patients, and in 5 patients there was wound site infection. One patient was done debridement and wash, and there was neurological deterioration in one patient, which improved in a few days on conservative treatment. Case number 1, we can see the AP and lateral radiograph showing the L2 fracture. We can see 3D CT scan to see the bony anatomy of the fractured vertebra. This was the case which we fixed in our department of neurosurgery in Radiological hospital. She was discharged within a couple of days. Second case, which also shows the L2 fracture vertebra, having 3D spine CT scan, and this was the during operation we take this image. If properly applied, height can be nicely restored. So the main technique is how to find the entry point and to put the screw in the proper direction. Conclusion is transpedicular screw fixation, including the fractured vertebra, gave excellent clinical and radiological outcome in majority of our patients. Fusion segment was small, biomechanically stronger than most of other types of fracture fixation. We therefore recommend putting intermediate screw fixation of the fracture vertebra in transpedicular screw fixation of dorsal lumbar spine fracture. Thank you. Thank you.